This video is titled Microforceps-assisted diagnosis of a cystic cyst lesion. My name is David Sanders and I'm a gastroenterology resident at Vancouver General Hospital. My collaborators on this project were Dr. Alvin Ting and Dr. David Schaefer. My supervisor for this video titled Microforceps-assisted diagnosis of a cystic cyst lesion is Dr. Fergal Donnellan. This video describes a 67-year-old female with incidental 7 cm cystic lesion in close proximity to the tail of the pancreas. The cyst was found when a CT scan was ordered to identify spinal pathology. This CT scan demonstrates the location and size of the cystic lesion, located between the posterior stomach and the pancreas. The initial EUS-FNA in 2016 drained 400 milliliters of fluid. The fluid amylase was 51 and the CEA 3.5. The cytology did not demonstrate any neoplasia. This initial fluid analysis was non-diagnostic, and the cystic lesion had reaccumulated 6 weeks later when a follow-up ultrasound was performed. We then decided to repeat the EUS with adjunctive biopsies of the cyst wall using the Moray microforceps made by US endoscopy. Linear endoscopic ultrasound was performed and the cyst was identified. A standard 19-gauge needle was used to puncture the cystic lesion. The microforceps were inserted via the 19-gauge needle, and its jaws can be seen opening within the cavity. Biopsies of the cyst wall were then performed, as can be seen in this portion of the video, with tenting of the cyst wall at the time of tissue acquisition with the microforceps. These are the samples obtained by the microforceps, and on the left is a standard hematoxylin and eosin stain. The sample is a low-grade spindle lesion with c-KIT and DOG1 stains positive. Immunohistochemical staining for DOG1 is demonstrated on the right. The lesion was negative for S100 and Desmond. GNAS and KRAS are both negative. Given these markers, the lesion was confirmed as a cystic gastrointestinal stromal tumor and not a mucinous cystadenoma. The patient underwent a laparoscopic wedge resection of the lesion when it increased in size and it developed a mass effect. The final pathology confirmed an exophytic gist. The lesion had low mitotic activity and was arising from the outer muscularis propria of the stomach. In conclusion, cystic cyst lesions are uncommon and can elude diagnosis. The diagnosis can be facilitated by biopsies of the cyst wall to allow for analysis with histology and immunohistochemistry. Microforceps biopsies are useful in cases where imaging, cyst fluid analysis, and cytology are insufficient to achieve a diagnosis. Thank you for watching.